So you should already have had some introduction to clinical prediction rules in your previous classes. In this lecture, we're going to dive a little bit deeper into clinical prediction rules, and what I'd really like you to be able to do is start thinking about clinical prediction rules and how they can be used within your research, as well as your clinical practice. It's very important to be able to use these in our clinical practice to be able to incorporate best practices into our careers and to create the best outcomes for our patients. So in this chapter, you should be able to identify what clinical prediction rules are and what clinical prediction rules are most relevant and useful for you as an athletic trainer. You're going to need to be able to find them and use them to help you with your diagnostic accuracy and to ensure that you are making sure that you can be the best athletic trainer you can be. So let's get into talking about clinical prediction rules. Clinical prediction rules are just simple decision-making tools. They help you determine the diagnosis, the prognosis, and the patient's response to treatment. They really just use algorithms, okay? So they combine variables. So, for example, they can combine history and mechanism of injury to help us determine the likelihood that an injury exists. Um, we can take a patient's history of glute med weakness and a mechanism of injury of planting and twisting over their leg, and that's going to help us determine the likelihood that they've sustained an ACL rupture. We can further combine more variables like a special test. So for this example, a Lockman's test, and that's going to help further help us to determine if there is indeed an ACL rupture or not. Uh, there are many already developed CPRs, but as we continue to progress as a profession, as athletic training as a profession, and through healthcare in general, you'll most likely find that not only will existing clinical prediction rules be improved, but more will be continued to be developed to help clinicians become better at assessing, diagnosing, and treating injuries. So there are several types of CPRs. Diagnostic CPRs are used to determine probabilities. They determine the probability that a patient has a condition of interest. So if a patient presents with X, Y, and Z, they're more likely to have a specific condition. If they only have X and Y, they're less likely to have that specific condition. If they only present with Z, they are even less likely to have that condition, or they don't have that specific condition at all, and maybe they have a different condition or injury that may also present with that symptom or that sign. Prognostic CPRs determine what is the outcome for patients with a certain condition who have specified characteristics. So how likely is the patient with characteristics X, Y, and Z to reach full recovery from their condition? Essentially, these help us determine how well will the patient do after sustaining a specific condition or injury. Full recovery, partial recovery, etc. What will the timeline be for this individual based on the characteristics they have? How will they respond to specific therapeutic modalities or exercise interventions? Okay, it's really just helping us determine how well they will recover based on the characteristics that they have both before and after an injury occurs. So we could look at prognostic CPRs for something like a concussion. Have they had previous concussions? Did they lose consciousness? How many symptoms do they have on their graded checklist? And how severe were those symptoms, etc. Lastly is interventional CPRs. So how likely would it be for an individual to respond to a particular intervention or interventions and have a successful outcome? So what is the likelihood that they are going to have a successful outcome based on the interventions that are used? This is something used in things like cancer treatment all the time. For example, like a female with breast cancer who's between the ages of 40 and 45 may be just as likely to have benefit from chemotherapy as an intervention as a female with breast cancer who's between the ages of 50 to 60 years old. This can also be used to help us identify if certain patients will tolerate specific interventions better than others. So patients with cancer who are between the ages of 40 and 45 may be able to tolerate chemotherapy 3 times a week for 9 weeks versus a patient who's 50 to 60 years old. They may only be able to tolerate chemotherapy 2 times a week for 9 weeks. And then we can look at each of these patient groups and how they respond to these differences in their interventions at the end of their 9-week treatment periods. So let's take some of these informal clinical prediction scenarios that we've talked about where we have a patient who has X, Y, and Z, and we are more likely to say that they have some specific condition. Okay, so that's actually part of the development of the clinical prediction rules. But actually developing CPRs is a little more rigorous, a little bit more rigorous of a process than just doing that. Okay, so we have step one, which is derivation. This is where you identify factors with predictive value, and that's done statistically. Now, hopefully, this is done more objectively than subjectively, but sometimes subjective factors can be worked in because they're very reproducible. So, for example, we know that a patient with plantar fasciitis often has pain with their first step out of bed in the morning. Or we also know that a person who has an Achilles tendon rupture, they'll often state that they feel like they got kicked or they got hit in the back of the leg, right? Those are factors that can help us, but they're subjective. And if we start combining those with things like positive Thomas tests, for example, then we are probably looking at a clinical prediction rule that can be developed. Some are easy to identify, like these examples with plantar fasciitis or gastroc soleus rupture, but most often we're looking at much more complex processes to include in our derivation step. Now, step two is validation, so the reproduction of the rule in different populations of patients. So once we have the factors that we have a predictive value, or the factors that have a predictive value, we're going to put them together, and then we have to validate that rule first on one population, and then we have to include additional populations to again validate that rule. And again, it has to be compared to a gold standard, so it's compared to a criterion reference study. And then step three is the impact analysis, and this shows evidence that the rule changes clinician behavior, and that change in behavior improves patient-oriented outcomes, or it reduces the cost of care to that patient. So again, the first step is derivation of the factors or variables that have some predictive power. For each individual variable that we might have in this new clinical prediction rule, we have to have 10 to 15 participants in an original study that's looking to develop those variables. So for example, if we have variables, if we have 5 variables, we need to have between 50 to 75 subjects enrolled in that original study. And then if we have 10 variables, we need to have 100 to 150 subjects enrolled. The reason for these numbers, as we've talked about in previous lectures, is that we need to account for any dropout or mortality rate with a study, and these numbers give us a much greater statistical power when the study has been completed. Data is then collected on these variables, and it is usually a binary choice. So that means we look at whether the variable is present or it is not, right? So was the test positive or was it negative? Did the patient state that they had experienced the variable of interest or not? Did this occur to the patient or did it not occur to the patient, right? It's all those things and more. So it is usually a binary choice, but it doesn't always have to be. If it is not one or the other, then we have the problem of like, well, if they score a 7 out of 10 or higher on this scale, then that's a positive for the test. Well, what's to say that that cutoff number at 6 or 7 is very well defined and it's not subjective, okay? Anyways, data is collected on those variables, and then the findings are compared with a reference standard, so a gold standard, a well-established and accepted diagnostic test or level of improvement in an interventional CPR. In medicine and healthcare, it's usually imaging or it's surgery, but it is some sort of very well-established and usually more expensive diagnostic tool or an expensive test or expensive intervention. Once that's all been done, and again, that would be a criterion reference, then a statistical analysis is performed to determine whether or not these factors are predictable, usually some form of regression, like a logistic regression or something along those lines is used. Then the relevant variables are determined and factored in, and then we put them all together to perform a predicting equation for whatever outcome is in question. So that is the derivation step. Table 13.1 gives us a really good hypothetical scenario for the step of derivation. So the target population here is active patients with medial elbow pain that lasts longer than 1 week. And just be aware that longer than 1 week, it may mean 8 days, or it may mean 8 months. Okay, so be aware of that. The predictor variables are listed here as pain with resisted wrist flexion, pain with pronation, point tenderness on the medial epicondyle, point tenderness over the wrist flexor muscle group. And that one in particular, we need to probably define a little bit better because the wrist flexor muscle group is pretty large. So what area of that wrist flexor muscle group is point tender, right? Numbness and tingling in the ulnar nerve distribution, decreased grip strength bilaterally, and that doesn't mean that they have decreased grip strength in both hands. It means that their one hand has decreased grip strength compared to their other. And then also a history of overhead throwing. Now, because we have 7 different variables of interest, we need to have between 5 and 10 subjects per variable. So in total, we need between 70 and 105 subjects included in our original study. Our reference criterion, or our gold standard, would be an MRI, so that we would have something to compare our variables to. The potential statistics, I mentioned that the most common is a logistic regression model to develop prediction variables. You could have a forward stepwise selection procedure, and then we also can use sensitivity, specificity, and likelihood ratios also. And then once the identified predictor variables of interest are determined, now we have only 4 that are of interest. We have pain with resisted wrist flexion, point tenderness over that medial epicondyle, decreased grip strength, and no tingling in the ulnar nerve distribution. And this is because if they had tingling over that ulnar nerve distribution, the pain could be coming from that ulnar nerve rather than that epicondylitis. So again, this is hypothetical, but it is a great example of the derivation step in developing CPRs. Validation is the next step in developing our clinical prediction rules and involves taking that rule that was developed and implementing it in different patient samples or within different clinical settings to see if it can still be applied. We're trying to validate the findings from the first step, and we're trying to see if they are valid in the original patient population and then attempting to see if they are externally valid amongst other patient groups. So can that rule that was developed be applied to different patient populations? We have to, and we definitely should, use different clinicians, different treatment settings, and different patient populations in order to truly validate the rule that we're developing and to see how applicable it is. There might be clinical prediction rules that only are applicable to specific patient populations or within only a specific clinical setting. So, for example, males versus females, or maybe one sport participant versus another sport participant. Okay. Validation has 4 different levels, and we will discuss those on the next slide. So as I just stated, there are 4 levels of validation. I'm actually going to start with level 4 because it is the lowest level of validation study. This is where the rule is really just being developed. You have the original study, and that original study often looks backwards in time, so it uses retrospective data rather than prospective data. And what this does is it just starts to give us an idea in the validation process as to whether or not that CPR is valid. And if it has some reliability and some clinical applicability. But we really should not be using this in place of anything else that's already been established, or anything that we might be doing until it's reached a higher level of validation. At level 3, now this is where we start to see some prospective studies starting to be used on similar patients and similar clinicians to that of the original derivation study. These are essentially starting to confirm what the original studies were showing. And now with this level of validation, we can start to use it if as if it's confirming what the original study were showing, but we have to use it with caution because the external validity has not been provided or established yet. So we should really only be using it on the patient population that was described in that original study. Level 2 validation includes even more prospective studies with an even wider variety of patients and variety of clinicians. Now we're just relying on those that came before us. We're getting more evidence and information to back up that this CPR is valid and that it can be used with a wider range of patients. We can start to use this one with some degree of confidence in a variety of settings and patient populations, but it is still not to be considered the end-all be-all of the clinical prediction rules. Lastly, clinical prediction rules with level 1 validation continue to use even more prospective studies with an even greater variety of patients and within different settings and with even more varieties of clinicians. And this level evaluates the impact on clinical practice. This level 1 of validation, is showing a great amount of evidence that supports its use for patient outcomes and clinical practice. So you can use this level in a variety of patient settings and be very confident that it is accurate and that it will improve your patient care. So the final step in the development of CPRs is the impact analysis. Now this takes a lot of time to get to, as you might expect, because we have to go through that derivation step and we have to go through the validation step, which takes a lot of time. Takes a long time to perform studies to reach different levels of validation. It takes a long time to identify and create that original clinical prediction rule. So we typically see this step occur after the CPR has reached level 1 validation, and now we're able to determine how much it affects clinicians and their clinical practice. But what impact analysis does is it studies the CPR to determine and demonstrate that that CPR has led to changes in the clinician's behavior, that it improves patient outcomes, it reduces cost of care to the patient, because remember, we're trying to develop these so that we can save a patient time and money when it comes to having to go and maybe get an expensive image done or maybe pay for long-term rehabilitation, right? And then lastly, it also helps create more cost effectiveness of treatments. The impact analysis is really conducted in one of 3 ways. First, and the highest level, is performing a true randomized controlled trial. If we want to actually see if something works, it needs to have clinical trials. And that highest level of clinical trial is a truly randomized controlled clinical trial. That's the gold standard for evidence-based on practice, or the gold standard for evidence-based practice. Because until we have randomized controlled trials, you're going to have a hard time doing a meta-analysis, which I guess is even the greater top gold standard. But for new interventions, a true randomized controlled trial is the best way to do it. Next is randomized controlled trial by setting. So this would be something like having 5 clinical settings utilize the new CPR and then 5 that don't utilize it. And then we're going to compare. What are the results? How is the patient care? What were their clinical outcomes? What were their costs, right? We're going to compare all of those. In the end, it's probably going to be the last of the 3 ways that we can conduct impact analysis, which is a non-randomized controlled trial. The clinical decision rule is a clinical prediction rule that's been validated and has had an impact analysis performed that shows significant change in the behavior of the clinician, the improved patient outcomes, reduced cost of care, and or improved cost effectiveness of treatment. It goes from a prediction rule to a decision rule, and it guides what the clinician must do, or at least what they should do. If you don't do what a clinical decision rule suggests or tells you that you should do based on the findings, and your patient has some sort of negative result or a consequence, or has poor care, then the responsibility is really on you as the clinician.